Hi, everyone. Wonderful to be here. My name is Jamie Jacobs. I'm a clinical psychologist at the Mass General Cancer Center, where I'm the program director for our Center for Psychiatric Oncology and Behavioral Sciences. And today I'm going to be talking about a study conducted in collaboration with Dr. Daniel Lahe, who was formerly at Mass General and now at Memorial Sloan Kettering Cancer Center in New York City. Dr. Lahe is the principal investigator, and I'm a co-investigator and site primary investigator on this project, which we call PROWESS, Prostate Cancer Wearables, Exercise, and Structured Supports. So a little bit of a background on why we conducted this research, specifically in Black and Latino men with metastatic prostate cancer who are taking androgen deprivation therapy. So we know that men from different racial and ethnic minority backgrounds tend to have lower quality of life than white men and other majority populations while taking androgen deprivation therapy. In fact, 50 to 60% of men who are white with prostate cancer on ADT engage in healthier behaviors, for instance, moderate to vigorous exercise, while men from minority backgrounds are less likely to engage in exercise, which is one of the health behaviors that accounts for a majority of the difference in quality of life between these racial and ethnic groups. This trend is seen in other health behaviors too that can relate to quality of life, and that has an especially important contribution to how men are living while they're taking ADT. Physical activity in and of itself can really reduce ADT side effects and promote quality of life. Some of these side effects we know significantly impact daily activities, people's routines, and their ability to live life meaningfully, or as they would before cancer. And physical activity can really contribute to the differences in health behaviors and quality of life, as I mentioned, that we see in these racial and ethnic groups. Exercise is known to improve side effects like hot flashes, joint pain, sleep disturbance, fatigue, and to improve quality of life. Certain populations, as I mentioned, like Black and Hispanic or Latino men, are more likely to experience barriers to side effect management and exercise. For example, they might have limited access to community resources to engage in exercise or physical activity, time constraints, other responsibilities to work and family that make it difficult to find the time to engage in exercise. Financial stressors might get in the way here too. They're more likely to have a sedentary lifestyle and comorbid health issues. And there are many cultural influences on decision-making when it relates to taking the time to be physically active or to exercise versus the other responsibilities and role obligations that they might feel driven to fill. There are really few interventions that exist to actually increase physical activity that specifically consider cultural relevance and cultural sensitivity for these patient groups and take into account these very specific barriers that Black and Latino men might encounter when trying to be more physically active and engage in health behaviors that might increase quality of life while taking androgen deprivation therapy. So because of this, we set out to try to intervene on physical activity, on side effect management while on ADT, and improve overall health behaviors and coping for Black and Latino men. Dr. Lahe was fortunate to receive a grant from the Treffler Foundation to start to really do some pilot and preliminary work in this area. So our first aim was to develop an intervention, a psychologically based and evidence-based intervention for Black and Latino men with metastatic prostate cancer taking ADT, focusing specifically on increasing exercise and improving side effect management. And we did this through a process that's in line with the National Institutes of Health stage model for behavioral intervention development, which starts in stage 1 by conducting an in-depth qualitative study with semi-structured interviews with the patients of interest, which here were Black and Latino men, as well as their caregivers, and conducting focus groups with what we call key stakeholders, like genitourinary oncology clinicians and other stakeholders in the community. And then from here, our second aim, once we developed the intervention, is to move on to the next stage of the NIH model, which is to really refine the intervention by actually delivering it to these men in an open pilot study and conducting exit interviews with them to find out what is it that what is it about the intervention that really hit home for them? What might they want to see done differently? How might we revise some of the study procedures or change the study design before we move into the next stage of the NIH model, which is to do a randomized controlled trial, sometimes a feasibility and acceptability trial first, and then an efficacy trial to see how the intervention improves the outcomes that we are interested in. So as I mentioned, we sort of moved through this model first with qualitative interviews. Here's an example of a patient who really was miserable taking ADT, so much so that he said, I'd rather be dead than to be miserable on this medication. My quality of life is so important to me. From stakeholders in the community, we presented this work at the Harvard Catalyst Equity Coalition and received feedback about what we might want to revise in the intervention. And then we worked together, Dr. Lahe, myself, other experts in the field, to really develop the intervention in line with a few models of intervention adaptation, like the typology of adaptation model and ADAPT guidance, that both consider how interventions might maximize cultural sensitivity and reduce barriers for cultural reasons, religious reasons, and other racial and ethnic minority considerations as we are trying to adapt the intervention into a new space. We came up with PROWESS, which is now a 6-session, culturally responsive group-based intervention, which targets physical activity, symptom management, and quality of life, and is delivered by psychology-trained therapists. These sessions are each about an hour to an hour and a half. They are weekly, so once a week for 6 weeks. We leave the possibility for them to happen over 12 weeks because there tends to be some conflicts with schedules, and we allow for flexibility there. Again, it's delivered by a psychologist and it's occurring over Zoom. So men sign into the group, they can all see each other and participate via video, but because of this, they never have to actually come into the hospital. So really reduces some of the barriers that we know to exist for these men and make it more feasible for them to engage in the intervention. Some of the intervention targets that we're considering that came about from these qualitative interviews, discussions with community stakeholders, are to use some of the evidence-based interventions that we know to exist and to adapt them, again, for Black and Latino men. So we do a lot of goal setting, self-monitoring. We give men a Fitbit during the intervention to wear so that they can track their physical activity and know if they're meeting their goals that they've set. For side effect management, we do a lot of psychoeducation about side effects, as well as introduce relaxation training to engage the relaxation response for stress management and other behavioral skills, and even outside referrals if necessary. For general management of distress and quality of life, we're using cognitive behavioral therapy, including reframing of thoughts, coping by identifying controllable aspects of stress and side effects, and enhancing communication with providers, trying to break down some of the barriers around mistrust and help them advocate for themselves when they're experiencing side effects that are really difficult to manage and impairing quality of life. There's also a big focus on community and social support by each of the participants giving each other support and ideas for coping, as well as informing them of resources that might be available in the community to promote physical activity. And some of the barriers that we see that have come up, I've addressed with these more racially and culturally specific questions. We talk about non-adherence to treatment. We talk about language barriers. We've translated the intervention into Spanish, so we have a Spanish-speaking group ongoing currently. And we talk about financial stressors and cultural influences on decision-making. For example, some of these questions, what does it mean for you to be more physically active? And how does that impact your values, beliefs, or attitudes? Or is there a way you were taught to cope in your family growing up, like not to complain about things, that it impacts how you talk about having prostate cancer or being on medication? And so these are just some examples briefly. And we've now moved into AIM 2, which is to conduct this open pilot study to get some information about how the intervention is operating within this patient population. So we've enrolled patients that are 18 or older. They're taking ADT for prostate cancer for at least 6 months. They're either Black or Latino, and they're receiving oncology care for right now at Mass General Cancer Center, although we're hoping to open enrollment with a future study to a broader patient population. And they're fluent in either English or Spanish. We've run 4 groups with 3 to 4 men in each group. Our current group is a Spanish-speaking group, as I mentioned. And so they attend these 6 weekly Zoom-based group sessions. They're wearing a Fitbit through the study. They complete questionnaires before and after the intervention, including a questionnaire about how satisfied they were with the program itself, and other questionnaires about physical activity. These are all validated measures used often in the oncology and mental health world that give us some information about their quality of life, their distress, their coping. And then they provide feedback as well in an optional exit interview. And we're going to be analyzing these exit interviews. We're in the process of doing that now. And just to share with you briefly a few things that have come about from men that have participated in the group. One said this program was a game changer. One of the things I learned about, it's important for me to ask what I want. So he's talking about advocating for himself with a medical team, and that what he got out was how to even talk to his friends and family about how to treat him the same way that they did before he got cancer. And this helped to reduce some of his distress. Another participant said, I think programs like this are really necessary in the Black community. No one ever talks about it. And he's referring to sex and the effects of ADT and having prostate cancer on sexual functioning. Nobody talks about having sexual problems or having prostate cancer. It's a great program to get to find out how to get the Black community and to make it a healthier community. These are just 2 examples of ways that men are seeming to really benefit from this. But the important next steps are to complete this open pilot and to make some refinements to the intervention if that's what's indicated based on our findings, and to refine the intervention to really make sure that we're making it most efficacious for men to increase physical activity and those components of social support and quality of life and side effect management, and to be able to scale this intervention in the future, perhaps getting to the point of being able to deliver it in a clinical setting. We're going to be exploring future funding sources based on the data that we collect from this study, because as I mentioned, within the NIH stage model for intervention development, the next step would be doing a more rigorous and larger pilot control trial where we randomize patients either to the group intervention or to a control group, and we look at how feasible it is for people to enroll in the study and stay in the study and attend sessions, and then that would lead us to a larger efficacy trial. And so for that, we are in need of grant funding, and this data that we're collecting from this pilot study will serve as that preliminary data to support our application. And then to further work with community partners and recruit from community and non-academic sites to make sure that our findings are generalizable to all patients. So a special thank you to the MGH Treffler Program for Cancer Care Equity for funding this project, and Dr. Lahe, the principal investigator, our co-investigative team, study therapists, research coordinators, and especially to all the patients who participated in the study. Thank you so much, and that concludes my talk.